Hello everyone and welcome back. Today's lecture is centered around a very common but highly complex phenomena, vomiting, or in medical terms, emesis. Now we have all experienced vomiting, whether from bad food, motion sickness, or a viral infection. We will start with the basic definition and mechanism of vomiting, explore how it's centrally coordinated through areas like the vomiting center and the chemoreceptor trigger zone, and then analyze what causes vomiting from GI problems to drug reactions and even psychological triggers. Then we will go deep into antiemetic drugs like 5-HT3 blockers and dopamine antagonists that help us treat this common yet sometimes dangerous condition. So, whether you are studying for an exam or brushing up on your clinical knowledge, stick with me as we break down into complex topics into step by step simple one. All right, let's start by understanding what vomiting actually is. In medical language, vomiting is defined as the forceful expulsion of stomach contents through the mouth, and it happens via a reflex pathway coordinated by a central nervous system. So, vomiting serves as a defensive mechanism, an intelligent way for the body to expel irritants, toxins, and even harmful pathogens from the gastrointestinal tract. But vomiting is not a single event, it involves multiple phases. First comes nausea, that unpleasant feeling in the pit of your stomach. It's subjective and often hard to describe, but you know it when you feel it. Then comes retching, where you go through the motions of vomiting but nothing comes out. It's like a dry run. Finally, the diaphragm, abdominal wall, and esophageal muscles contract in sequence, leading to the final act, emesis. We also have a special type called projectile vomiting, which happens suddenly without any nausea. This can indicate something more serious, like increased pressure inside the skull, so we must treat it as a red flag. All of these, nausea, retching, vomiting, is centrally regulated primarily in the medulla oblongata, and it requires the coordinated activity of several muscle groups, autonomic pathways, and brain regions. So, vomiting is much more than gut issue, and it's full body reflex with deep neurological roots. Now let's get into the actual mechanism how vomiting happens through a neural reflex arc. Just like knee jerk reflex, vomiting has its own afferent and efferent limbs. The process begins when signals are received by the vomiting center, a functionally defined area in the medulla oblongata. This area collects sensory inputs from various sources. From the GI tract, signals come through the vagus nerve when the stomach or intestine detect irritants. The CTZ or chemoreceptor trigger zone picks up the toxins or drugs in the bloodstream. The vestibular system sends motion signals. Even your cortex and limbic system can trigger vomiting in response to smells, stress, or even emotions. Once enough input builds up, the vomiting center activates efferent outputs to the muscles in the abdomen, also diaphragm, esophagus, and the pharynx, which leading to that classic expulsion event. So it's a gut reflex. This is a full neuromuscular event organized by your central nervous system. The chemoreceptor trigger zone or CTZ is like a chemical surveillance post for your brain, located in the area postrema at the base of the fourth ventricle. It's outside the blood-brain barrier, which allows it to detect toxins and drugs directly from the blood and the cerebrospinal fluid or CSF. The CTZ is packed with receptors like dopamine, serotonin, histamine, substance P, and when these are activated, they send signals to the vomiting center to initiate the emesis process. This is why many antiemetic drugs work right here, blocking D2 receptors with metoclopramide or 5-HT3 receptor with ondansetron prevents the CTZ from firing up the vomiting response. Have you ever felt sick while reading in a moving car? That's the vestibular system at work. Located in your inner ear, it detects motion and balance. When there is a mismatch between visual and motion output, the brain gets confused and may respond with nausea and vomiting. This type of vomiting is mediated through H1 and muscarinic receptors, which is why antihistamines like meclizine help with motion sickness. Similarly, your brain's higher centers like the cortex and limbic system can also trigger vomiting in response to pain, trauma, emotions, or even seeing something gross. So, vomiting really is a brain gut experience. Vomiting unfolds in three phases: nausea, retching, and emesis. Each one has a distinct physiological pattern. In nausea, the stomach slows down and you get that watery mouth feeling. During retching, the diaphragm and abdominal muscles contract, but the upper sphincter stays closed. Finally, in the vomiting stage, the LES reflex relaxes and the glottis closes and the upper sphincter opens, allowing the stomach content to be forcefully ejected. So, vomiting while protective in short bursts can become a serious clinical problem when it's frequent or prolonged. Let's break down the pathophysiological consequences and potential complications. First up, there is a major issue with fluid and electrolyte loss. Each episode of vomiting throws out sodium, potassium, and chloride. Over time, this can cause hypokalemia, hyponatremia, hypochloremia, or imbalances that disrupt nerve function, also heart rhythm and muscular activity. The loss of hydrochloric acid from the stomach leads to metabolic alkalosis, a condition where the blood becomes too basic. The kidneys try to compensate, but this can worsen potassium loss, further complicating things. Mechanically, frequent forceful vomiting increases pressure and the gastroesophageal junction, which may cause tears. One such condition is Mallory-Weiss syndrome, and in rare cases, a full thickness rupture can occur, known as Boerhaave syndrome, which is a medical emergency. Another big concern is aspiration, when vomit enters the lungs instead of being expelled out. This is especially dangerous in unconscious patients, leading to aspiration pneumonia. Chronic vomiting also leads to nutritional deficiencies and weight loss, especially in patients with cancer, pregnancy complications, or GI disorders. And don't forget about the red flags like vomiting, blood, black coffee ground like vomitus, projectile vomiting, especially in infants or those with head injury. All signals something serious. Always look out for signs of dehydration like sunken eyes, dry mouth, reduced urine, or even hypotension. Vomiting can be triggered by many different causes, ranging from minor to life threatening. Gastrointestinal causes include infections like gastroenteritis, food poisoning, ulcers, or blockage. These irritate the stomach or intestine and activate the vomiting reflex. Central nervous system causes like head injury, brain traumas, brain tumors, or increased intracranial pressure can directly stimulate the brain's vomiting center, often without any nausea. The vestibular system, which helps the helps with the balance, can cause vomiting in motion sickness or inner ear disorders like vertigo. Metabolic and systemic causes include pregnancy, kidney failure, diabetic ketoacidosis, or drug toxicity from medications like chemotherapy or opioids. Finally, psychogenic triggers like stress, fear, or anxiety can also stimulate vomiting through higher brain centers. So, vomiting is not just about stomach, it's a response that can originate from the gut, brain, inner ear, or even emotions. When it comes to treating vomiting, we turn to antiemetic drugs. These work by blocking the neurotransmitter that trigger the vomiting reflex in the vomiting center, chemoreceptor zone, trigger zone, and GI tract. So let's look at the major classes. First, we have the 5-HT3 receptor antagonists like ondansetron. These are especially effective for chemotherapy induced vomiting and work by blocking serotonin at both CTZ and gut. Then come the dopamine D2 receptor blockers like metoclopramide and domperidone. These target CTZ and are useful in vomiting due to GI causes, medications, or even migraine. So, for vomiting linked to motion sickness or vertigo, we use H1 blocker like promethazine and diphenhydramine, or muscarinic antagonists like hyoscine. They block the signals from the vestibular system to the brain. We also have NK1 receptor antagonist induced, which is like aprepitant, which are powerful drugs for delayed chemotherapy induced vomiting. In resistant cases, cannabinoids like nebilone may be used, and corticosteroids like dexamethasone are often added to enhance efficacy, especially in cancer therapy. So remember, vomiting has multiple pathways. So antiemetics are often used in combination to block different neurotransmitters for better results. So the choice depends on the causes of vomiting, timing, and patient specific factors. So to wrap it all up, vomiting is not just simple gut reaction. It's a complex, finally coordinated neurological reflex involving multiple pathways and systems working together. From the anatomy and physiology behind the vomiting center and reflex arc to the pathophysiology, causes, and the pharmacology of antiemetic drugs, we have all covered about vomiting. Now, it can be a protective mechanism and a sign of something serious. So, thanks a lot for watching. If you found this helpful, don't forget to like, share, and subscribe for more high yield exam focused lectures just like this one. See you in the next video.